Hello everyone and welcome to Sketchy Pharm. We begin with our first episode of our mini-series of cardiac drugs. But before we start, we need to first revisit the basic principles of the physiological processes that maintain our cardiovascular system. Here we begin with the renin-angiotensin-aldosterone system, also known as the RAAS system. We start off with angiotensinogen. Angiotensinogen is produced in the liver and is converted to angiotensin 1. Now, the conversion to angiotensin 1 is facilitated by an enzyme known as renin. Renin is mainly produced and released into the circulation by the juxtaglomerular cells located in the renal afferent arterioles. When renal blood flow is reduced, these cells detect this reduction in blood flow and secrete renin. Angiotensin 1 is then converted into angiotensin 2, its more active form, and this conversion is facilitated by another enzyme. This enzyme is known as angiotensin converting enzyme, or also known as ACE, and is the prime target of the ACE inhibitor. ACE is secreted in the lungs by cells in the endothelium of the blood vessels. Angiotensin 2 has a variety of roles. It stimulates water and sodium reabsorption, as well as promoting potassium excretion, which goes hand in hand with the stimulation of ADH from the posterior pituitary gland and aldosterone from the adrenal gland. Angiotensin 2 also promotes vasoconstriction, thereby increasing mean arterial pressure, and this is as a result of raising total peripheral resistance. Angiotensin 2, over a long period of time of stimulation, can cause cardiac remodeling, and this is as a direct result of the sympathetic activation. Whilst we're here, we'll talk about the bradykinin. Bradykinin is a potent vasodilator and is broken down into its inactive metabolites by the same enzyme ACE. Now, in the setting of ACE inhibitors, the level of angiotensin 2 in the blood drops, bradykinin is also built up, and as a consequence, the effects of angiotensin 2 are reduced. There's less water reabsorption, less ADH aldosterone secretion, less vasoconstriction, and less sympathetic activation. Effectively, there's a decrease in mean arterial pressure. And in the consequence of bradykinin, there is a build-up of bradykinin. Side effects of ACE inhibitors, as a result, would include hypertension and asymptomatic dizziness, include hyperkalemia as a result of a reduction in potassium excretion by aldosterone, and also cough and angioedema, and these are both secondary to the buildup of bradykinin. Now, angiotensin receptor blockers don't have an effect on bradykinin, rather they just block the effects of angiotensin 2. The suffix for ACE inhibitors are prils, and angiotensin receptor blockers are sartans. Now, the indication for these medications are as follows: hypertension in the setting of causing or promoting vasodilation, as well as the natriuretic and diuretic effects of ACE inhibitors and ARBs. They reduce the blood volume and thus cardiac output. In the setting of chronic heart failure, they reduce in the setting of chronic heart failure with reduced ejection fraction, they decrease the afterload and preload, and also reduce the long-term effects of cardiac remodeling by the promotion of the sympathetic nervous system. They also are used in the setting of diabetic nephropathy and prevention or progression of renal failure. This is particularly in the case of patients with proteinuria greater than 1 gram a day. They're also used in the setting of patients that are post-myocardial infarction, as this has some secondary preventive effects. That's a quick overview of the RAAS system and the ACE inhibitors and ARBs. Please tune in to our next episode on calcium channel blockers and beta blockers. Thank you.